Good morning, my dear professors and colleagues. I'm honored by the invitation in this prestigious conference, and I will talk about the emerging role of whole body MRI in pediatric cancer patients. Imaging is fundamental for the diagnosis and management of pediatric patients with cancer and cancer predisposition syndromes. Whole body MRI has emerged as a versatile tool for pediatric oncologic imaging with the potential to spare the children from ionizing radiation imparted by conventional modalities such as CT and PET. It enables simultaneous high-resolution locoregional staging and, at the same time, wide field of view distance staging with a superior evaluation of the brain, spine, liver, and bone marrow. Many protocols have been advocated for whole body MRI with still no consensus on the protocol. But the most commonly utilized sequences are the coronal stare. Coronal stare has an excellent ability to suppress the fat with ability to delineate the lesions, especially in the bone marrow. Coronal T1, this is an image for coronal T1, also has the ability to characterize and to detect the osteomedullary lesions. Axial diffusion, it provides some sort of functional data. This is an image. Laser pointer. Oh, okay. This is axial diffusion, showing the tumor. It was a pulmonary tumor, and this is the ADC image. We also have the ability to invert the diffusion sequence to give a PET-like picture. As in any MRI examination, it is tailored according to the clinical setting and the indication. Sometimes we add some sequences like axial T2 in the assessment of intraspinal extension. We add sagittal stare in cases of neuroblastoma or Langerhans histiocytosis. So it is a tailored examination. In whole body MRI, we don't give contrast medium. Actually, what we do is dividing the body into different stations and image each separately. Then on a workstation, we compose the stations to give a seamless coronal image. Its current application is in cancers and in cancer predisposition syndromes. In cancers, it has been studied extensively and applied in round cell tumors as neuroblastoma, Ewing sarcoma, rhabdomyosarcoma, as well as Langerhans histiocytosis. And in cancer predisposition syndrome, it has established role nowadays. For example, in Li-Fraumeni syndrome, hereditary retinoblastoma, and NF1 and NF2. Starting by Langerhans histiocytosis, which is a multi-system neoplastic disorder, encompasses the bone, skin, CNS, liver, spleen, nodes, and lungs. The imaging features are the skeletal findings in 80% of the cases, most commonly affecting the skull, the spine, the mandible, the pelvis, and the long bones. CNS involvement, which occurs in 15% of the cases, most commonly affecting the posterior pituitary gland with pituitary stalk thickening. Hepatomegaly, splenomegaly, and lymphadenopathy. Actually, the whole body MRI can detect all of these findings except for the CNS involvement, which needs a dedicated contrast-enhanced MRI. This is a case of Langerhans histiocytosis showing an expansile bone lesion involving the left acromion as well as the right inferior pubic bone. And this patient was histopathologically proven. This is a magnified image for the left acromion and the inferior pubic bone. The second application is in small round cell tumor. MRI generally excels in local evaluation and staging in these tumors. And regarding the distant staging, whole body MRI is superior to skeletal scintigraphy and potentially equivalent to FDG PET for skeletal metastases, which are the primary concern in many small round cell tumors. This is a case of histopathologically proven neuroblastoma. This is a coronal stair image for the lower limbs showing focal bone marrow infiltration. This is a T1 out of phase confirming its metastatic nature. And this is this patient undergone at the same time PET-CT just afterwards, confirming the lesion. طبعا neuroblastoma السوبيريور او الجولد ستاندرد imaging هو ال MIBG scan بس it's not available, and we use FDG PET as alternative in the staging. And currently whole body MRI gives equivalent results. This is another case of neuroblastoma. Actually, this patient undergone the PET-CT first and didn't show the bone marrow infiltration, which was very minimal. And the bone marrow biopsy, it's a lengthy procedure and it takes around 2 weeks for the results to show. So at first, they treated this patient as low risk. Whole body MRI was performed just after the PET-CT, delineating the bone marrow infiltrates, and it was upgraded to a high-risk neuroblastoma. And afterwards, the bone marrow biopsy confirmed the bone marrow infiltration. This is a case of Ewing sarcoma. The primary was in the right iliac bone, and the whole body MRI showed the bone marrow infiltration of the left proximal femur, which was barely perceptible in the CT. In this, in the same case, also it showed another focal bone marrow infiltration of the distal femur, and this is a coronal stair, and this is a coronal T1 delineating the infiltration. Although the whole body MRI is not the primary screening tool for pulmonary metastasis, but in this case it showed the pulmonary metastasis. This is a 9-year-old case of rhabdomyosarcoma, which was metastatic to the appendicular skeleton, including the humerus, both femora, both tibia. And this is a conventional MDP bone scan, shows the corresponding lesions. The second category of application is cancer predisposition syndrome. These are syndromes encompasses a spectrum of conditions associated with high risk of neoplasia. Many are attributable to a known or inherited or de novo germline pathogenic mutation. Examples, it has a lot of examples. The most famous is Li-Fraumeni, hereditary retinoblastoma, NF1, NF2. Recently, in the recommendations by the American Association for Cancer Research, whole body MRI was formally added in the screening of these patients. For example, in Li-Fraumeni, hereditary paraganglioma pheochromocytoma syndrome, hereditary retinoblastoma, with the time intervals also added. I'll talk about Li-Fraumeni syndrome. It is one of the most aggressive cancer predisposition syndrome and predisposes to a wide range of malignancy, beginning in early life. Tumors develop in 40% of the patients by the age of 18 years. Most common malignancies are osteosarcoma, brain tumors, including glioma, medulloblastoma, choroid plexus papilloma, adrenocortical carcinoma, and soft tissue sarcoma. This is a patient, 2-year-old patient, was genetically known to be Li-Fraumeni syndrome, and he underwent whole body MRI for screening of a tumor that showed a small left adrenocortical adrenal carcinoma. And just this by screening by whole body MRI. The second cancer predisposition syndrome is hereditary retinoblastoma, which is caused by RB gene mutation, accounting for 40% of all retinoblastoma cases. And as we know, the hereditary retinoblastoma, they predispose to bilateral retinoblastoma, and they manifest earlier than other retinoblastoma in early life. They develop concurrent midline intracranial primitive neuroectodermal tumor, giving the designation of trilateral and quadrilateral retinoblastoma. Whole body MRI can serve as an effective radiation-free modality for evaluating distant metastases from retinoblastoma. This is a case of surgically managed retinoblastoma, but unfortunately he developed widespread osseous metastasis involving the appendicular skeleton and the facial bones. And it is very evident on coronal stare image of whole body MRI. Also, the survivors of the hereditary retinoblastoma patients are predisposed to develop a second malignancy in late childhood, sometimes treatment-related as after radiotherapy, including osteosarcoma, soft tissue sarcoma, melanoma, cancers of the brain, orbit, and nasal cavity. Whole body MRI screening for late malignancy hereditary retinoblastoma survivors has been advocated by the AACR starting at the age of 8 years, providing a radiation-free tool for screening. Lastly, NF1. NF1 is characterized by variable expression of neurofibroma, optic pathway glioma, and many other manifestations. They are predisposed to several malignancies, however, with far lower overall cancer risk in childhood compared to other cancer predisposition syndromes. Most common is malignant peripheral nerve sheath tumor, which typically develop on a pre-existing benign plexiform neurofibroma. The goal of whole body MRI screening in NF1 is to stratify the risk on the basis of plexiform neurofibroma burden, as well as to identify the suspicious lesions that warrant further investigation. But because the malignant peripheral nerve sheath tumor is uncommon in the pediatric population, the AACR recommendation limited the whole body MRI screening to a single examination between the age of 16 to 20 years. This is a coronal stare whole body MRI for a patient with NF1, shows multiple and extensive plexiform neurofibroma along the right brachial plexus, along the right bilateral dorsal spinal nerve roots, lumbar spinal nerve roots, and the sacral and pelvic nerve roots. So to sum up, what are the strengths of whole body MRI? First of all is lack of ionizing radiation, exquisite soft tissue characterization, especially the brain, the liver, the bone marrow, with superior performance when compared with most other conventional imaging techniques. It's a versatile tool, highly adaptable to the patient and indication, while wide field of view acquisition is optimized for screening of cancer predisposition syndrome, while targeted regional sequences may be added in local tumor assessment. While formal guidelines for the use of whole body MRI in staging and surveillance of pediatric cancer patients do not yet exist, however, recommendations for its use in cancer predisposition syndrome have recently emerged. What are the limitations? Whole body MRI is not considered reliable for detecting small lung nodules smaller than 6 to 8 millimeter. So we still use the CT for screening of pulmonary metastasis. Also, subcentimeter lymph nodes can also be missed and misclassified as benign, as the nodal evaluation is primarily based on morphologic criteria, not on functional criteria as in PET. So its application in lymphoma cannot be applied or utilized. Thank you.